establish uniform definitions of sepsis and the systemic inflammatory response syndrome, or SIRS. For consistency, this committee describes SIRS and sepsis as cases in which at least two of the following physiologic domains are present: fever or hypothermia, heart rate above 90, respiratory rate above 20, and either leukocytosis or leukopenia. Although it's not explicitly described in the consensus statement, why would they have set the heart rate cut off at 90 if they believe the normal range to extend above this? It's logical to conclude that the committee also felt that 90 was the upper limit of normal. The last problem with the traditional range 60 to 100 is its history. Where exactly did this range come from originally? Well, it goes back to the earliest days of electrocardiography. In 1928, the New York Heart Association published their first edition of nomenclature and criteria for diagnosis of diseases of the heart. In this book, they defined something called, quote, regular sinus rhythm as a heart rhythm originating from a structure in the right atrium called the sinus node, from where it normally originates, and as having a rate between 60 and 100 beats per minute. But 1928 was decades before any formal study was conducted into the normal distribution of heart rates in the population. So how and why could the New York Heart Association come up with such a range? Well, a group like Charles Kossman, an early member of that group, it was for the purposes of standardizing electrocardiographic nomenclature. These limits and terminology are used principally for convenience and uniformity of designation. They do not define normality except in a gross way. However, in 1843, that same New York Heart Association renamed regular sinus rhythm as normal sinus rhythm, a decision which may have been responsible for creating this whole misconception to begin with. And if that didn't feel arbitrary enough, consider why the specific range of 60 to 100 was the one chosen for standardization. Standard electrocardiograms are printed on graph paper, which is divided into large boxes, 5 millimeters on a side, which are then further subdivided into 25 smaller boxes, 1 millimeter on a side. It's the large boxes that we're interested in. The ECGs are printed out at a rate of 25 millimeters per second. Therefore, along the x-axis, each large box of 5 millimeters represents 1/5 a second, or 200 milliseconds. This is the standard convention since before electrocardiography was really introduced commonly into clinical practice. As a consequence of this convention, an interesting trick for quickly estimating heart rate becomes apparent. The heart rate is equal to the number of large boxes between successive spikes, known as QRS complexes, divided into 300. So there are 2 large boxes between each QRS complex. The rate is 300 divided by 2, or 150 beats per minute. If there are 4 large boxes between each QRS complex, the rate is 300 divided by 4, or 75 beats per minute. How this becomes relevant to our 60 to 100 range is that when one is trying to determine if something is normal sinus rhythm or a tachycardia, that is a rate that's too fast, if we use 100 as our cutoff, one only needs to see if the number of large boxes separating complexes is more or less than 3. More than 3, the patient has normal sinus rhythm. Less than 3, the patient has a tachycardia. That can be determined by inspection instantaneously. However, if we use 90 as our cutoff, we will need to see if the number of large boxes separating complexes was more or less than 3.33. A little more awkward and not quite as automatic. So in essence, the decision to make the upper bound of the normal sinus rhythm at 100 was because it allowed for a trivially easier time interpreting ECGs. And even this ridiculous reason has been made obsolete by the use of ECG machines, which now automatically calculate the rates with extremely high reliability. So the traditionally heart range, or normal heart rate, is not supported by evidence, it's not supported by expert opinion, and originates from a completely arbitrary quirk in how ECGs are reported. There's just one more issue to consider. That is, what do we even mean by the word normal when we discuss the normal heart rate? Are we referring to the statistical average in the general population? Or are we referring to the statistical average only in those patients who are known or suspected to have no cardiovascular disease? Or are we referring to a heart rate that will minimize chance of future cardiovascular disease? Put more simply, does normal mean typical, or does normal mean healthy? A 1990 study looked at the association between heart rate and mortality in 1,800 patients who were admitted to the hospital with a heart attack. This graph here shows the patient's mortality in the first year after the heart attack as a function of their final reported heart rate immediately prior to hospital discharge. We see that the mortality for heart rates of 50 to 89 are uniform, but once the rate of discharge creeps above 90, mortality starts to climb pretty rapidly. But the danger of faster heart rates isn't limited to just patients who've had heart attacks. In a study of 56,000 patients without known heart disease, the faster the resting heart rate, the increased risk of a major adverse cardiovascular event, such as a heart attack or cardiac arrest. And this trend persisted even after statistical adjustments were made to account for the presence of high blood pressure, high cholesterol, diabetes, smoking, obesity, and lung disease. So even if one believes that resting heart rates of 90 to 100 are statistically within 2 standard deviations on average, which they probably aren't, they don't seem to be markers of good health. So going back to our original question, what is a normal heart rate? Well, it depends on who your patient is and what you mean by normal, but it's probably not 60 to 100. Thanks for watching my experiments in a new video style on this channel. Please let me know what you think of it in the comments. Keep in mind that if I continue to make some videos in this style, they'll be occasionally mixed in with my typical MedEd material and will not be displacing it. And if you're new to my channel, and this is the first video of mine you've seen, welcome. Please don't forget to subscribe, and that way you won't miss out on any of the videos to come. video in the series on interpreting chest X-rays. The topic is the systematic approach and normal chest X-ray anatomy. The learning objectives of this video are to be familiar with the systematic approach to interpreting chest X-rays and to know the correlation between anatomy and the normal shadows on the X-ray. Before just presenting a systematic approach, I first wanted to mention a couple of important principles about it. The systematic approach is most important for the clinician's least experience with reading chest X-rays, since it reduces the chance that important findings will be missed. All aspects of chest X-ray interpretation should be included. The individual elements of the approach should be examined in a sequence that's either logical and or easy to remember. And there is no one best system, though all should begin with an assessment of the film's technical quality. So the system I teach trainees is informally referred to as the ABCDEF system. It's not the only one, but it's certainly the most common, at least in the US. It's also not perfect, but it's easy to remember. Each of those 6 letters refers to a specific anatomic structure. Even before the A, we need to assess the technical quality. Then A stands for airways, B for bones and soft tissue, C for the cardiac silhouette and mediastinum, D for diaphragm, which also includes assessment of the gastric air bubble, usually located under the left hemidiaphragm, E for effusions, in other words, assessment of the pleura, which actually includes findings beyond just pleural effusions, and F for fields, that is, the lung fields. Lastly, although it's not exclusively part of the mnemonic, is an assessment of lines, tubes, devices, and prior surgeries, such as sternotomies and valve replacements. Aside from the fact that it's easy to remember, another nice thing about this mnemonic is that the lungs are examined near the end. This is a good idea because normally the lungs are the area of greatest interest and the most likely to be abnormal. Therefore, once the clinician plans down the priority there, it's very easy for her to forget examining the rest of the film. I've seen more than one rib fracture due to distraction over acute lung pathology. You may have noticed that the list of items here lines up really nicely with the remaining videos in the series, which of course is not a coincidence. But before you can identify pathology of each of these anatomic structures, you first need to know where they are on the X-ray and what they normally look like. So let's go through the X-ray anatomy of A to F one at a time. A is for the airways. There are 3 anatomic airway structures that are typically visible on a normal X-ray. They are the trachea, which is normally in the midline, and the right and left main bronchus. Remember that the patient's right will be on the left side of the screen. To help you visualize these structures, let me superimpose a drawing of them. The left main bronchus tends to take off in the trachea at a slightly more horizontal angle as compared to the right, which is why aspirated foreign bodies, if small enough, are more likely to end up in the right lung than the left. And it's also why endotracheal tubes, if advanced too far, end up in the right main bronchus, blocking off ventilation to the left, rather than vice versa. I'll take the drawing away again so you can try to see the airways on your own. The next set of structures is the bones. There are 4 types of bones, easily visualized on a PA and lateral X-ray set. First is this structure, which as you probably know, or could guess, is a rib. There are 2 radiographic components of the rib on the PA film. The posterior rib, which is easier to see and is oriented horizontally, and the anterior rib, which is harder to see and is oriented at a 45-degree angle. The next bone is the clavicle, located up here. There's obviously a right and a left one. The sternum is sometimes visible on the lateral film, but is often obscured by soft tissue in the anterior chest wall. Then are the vertebral bodies, more easily visible on the lateral film, but usually seen on the PA as well, provided that the technical quality is adequate. Then there is the cardiac silhouette and the mediastinum, which I think logically should be evaluated together. There are a lot of anatomic structures which compose the silhouette here. I'll start by outlining it, and then label what each bump, knob, or side corresponds to. You will usually also be able to see another vertical line running just to the patient's left of vertebral bodies, which corresponds to the left side of the descending aorta. To make it easier to visualize, here's a drawing of the heart and great vessels. The one structure on the patient's left, called the aortopulmonary window, may be unfamiliar to some viewers. This is an important space between the aortic arch and the pulmonary artery, where one will find the recurrent laryngeal nerve and lymph nodes. And then I'll take the drawing away and try to appreciate those various structures. Moving on, the diaphragm and pleura, which also makes sense to evaluate together. So here are the right and left hemidiaphragms, as seen on the PA view. It is normal for the right hemidiaphragm to be slightly higher than the left, since it will reduce the liver directly beneath it. While looking at the diaphragms, it's important to remember that there aren't any truly flat structures in the body. For example, the hemidiaphragms are curved in 3-dimensional space. As you might be able to appreciate when comparing the PA to the lateral, the hemidiaphragms as seen on the PA really just represent the superior-most aspect of the diaphragms. The pleura, which is a double membrane that surrounds each lung, is outlined here, but is normally invisible due to its thinness. However, knowledge that the pleura is there is essential for diagnosing pneumothorax, pleural flax from asbestos exposure, and pleural thickening. In addition, there are spaces on either side where the diaphragm meets the thoracic wall. These 2 spaces seen on the PA are usually called the right and left costophrenic angles, but the term costophrenic sulci would probably be more semantically accurate in most circumstances. The space in the back on the lateral film has several very similar names, the most common of which is the posterior costophrenic angle. There's also usually a small pocket of air visible under the left hemidiaphragm. This usually represents air in the stomach, in which case is called the gastric air bubble, although occasionally it can be unclear as to whether the gas is in the stomach or in the intestines. Finally, the last structures of the chest X-ray are, of course, the lungs. The anatomic structures in the lungs to worry about when interpreting X-rays are the fissures between the lobes and the lobes themselves. First is the horizontal fissure located here. There's only one, and it's on the right side. Here is its location on the lateral film. It's the only one of the three fissures that is commonly visible in normal X-rays, which is because a significant portion of the plane of the fissure is parallel to the direction of the X-ray beams. However, it's only visible on the PA, which is why the fissure there is represented by a solid line, and the fissure on the lateral is represented by a dotted line. Then there are the right and left oblique fissures, neither of which is usually visible in either view. As you can probably guess, if you didn't already know it, the fact that there are two fissures on the patient's right means that the right lung is divided into three lobes, while the one fissure on the left divides the left lung into two lobes. Here's the location of the right upper lobe, and the right middle lobe, and finally, the right lower lobe. Notice that because the oblique fissure runs obliquely, as seen in the lateral view, the lower lobe extends almost all the way to the apex of the lung. This will be true on the left side as well. As a consequence, if only the PA or AP views are presented without a lateral, it's almost impossible to tell what lobe a visualized nodule or mass is located in, unless it's seen in the uppermost part above the lower lobe's posterior extent. Here's the left upper lobe, and finally, the left lower lobe. That concludes this video on the systematic approach and normal chest X-ray anatomy. If you found it helpful, please remember to like or share it. The next video will discuss the assessment of a chest film's technical quality. Veterans Hospital and Stanford University. Today I'll be talking to you about the characteristics and identification of heart murmurs. Here are the learning objectives of this talk. First, to be able to understand the basic physiology behind the generation of murmurs. Second, to be able to describe the specific characteristics of murmurs using standardized terminology. Finally, to be able to identify the most likely underlying cardiac pathology based upon the characteristics of a heart murmur. There will be many audio clips along the way, and to assist with the last learning objective, there will be 5 example cases at the end where you will be asked to identify the underlying cardiac disease from the audio clip. For the purposes of this talk, I will be assuming some background knowledge in cardiovascular physiology, as well as a very basic knowledge of the common forms of valvular heart disease. I will start by spending just a minute on the physiology of murmurs. Murmurs are acoustical phenomenon produced by turbulent blood flow. They can occur in a wide variety of locations in the body and in a variety of clinical settings. When the murmur occurs outside of the heart, for example, in an abdominal aortic aneurysm, or narrowing of the carotid artery, they're usually referred to as bruits. Despite the name being different, murmurs and bruits represent the same type of phenomenon. The chance that blood flow will be turbulent in any given situation and thus produce a murmur is dependent upon its Reynolds number, with turbulence being more likely when the Reynolds number is higher. For those of you who have not recently studied for the MCAT, the Reynolds number can be calculated from the density of the fluid times the diameter of the vessel or orifice times the velocity of flow, all divided by the viscosity of the fluid. Within the heart, the most important of these parameters are the viscosity and the velocity. And squeezing blood through a pathologically narrowed orifice will increase the velocity out of proportion to the decreased diameter. Thus, turbulent flow is most likely when either there is an increased velocity of blood through morphologically normal structures, as seen during hyperdynamic states, or as a consequence of the blood velocity being increased by compression through a narrowed structure. Alternatively, decreased blood viscosity can also result in a murmur. Let's take a quick look at the etiologies of murmurs by physiologic mechanism. First, decreased blood viscosity. The only example of this is anemia. Next, decreased diameter of a vessel, valve, or other orifice. Here we have valvular stenosis, coarctation of the aorta, and a ventricular septal defect. Then there is increased velocity of blood through normal structures, as seen in hyperdynamic states such as sepsis and hyperthyroidism. Finally, a mechanism that I didn't previously mention is regurgitation across an incompetent valve. The turbulence caused by this is due to an abnormal morphology of the valve, which sets up eddies in the flow of blood which cannot be easily accounted for by Reynolds number. Now I will talk about the specific characteristics of murmurs. Although often the cardiac portion of a patient's physical exam may be something like stop murmur present, such a vague statement is of little diagnostic help. Murmurs can and should instead be described based on a number of specific characteristics. They are timing, location and radiation, shape, pitch, intensity, subjective quality, and the response to specific physiologic maneuvers. Therefore, a much more helpful statement of a cardiac exam might be, quote, harsh, grade 3, early peaking crescendo decrescendo systolic murmur, loudest at the right upper sternal border and radiating to the carotids. Any experienced clinician hearing this description will immediately become concerned about severe aortic stenosis. A couple extra words transform a near meaningless statement into something of great diagnostic value. So let's go through what each of these characteristics mean one at a time. When one talks about the timing of a murmur, It is the timing of the murmur relative to the cardiac cycle. Specifically, is the murmur present in systole, diastole, or both? It is the single most important characteristic that will aid in the diagnosis of an associated abnormality. Systolic murmurs are by far the most common. They comprise greater than 95% of all murmurs that you'll hear among hospitalized patients. Etiologies include slow murmurs caused by hyperdynamic states or anemia, aortic and pulmonary stenosis, mitral and tricuspid regurgitation, VSDs, and aortic outflow tract obstruction, which can be caused by hypertrophic obstructive cardiomyopathy. Diastolic murmurs include aortic and pulmonic regurgitation and mitral and tricuspid stenosis. Among American adults, detectable diastolic murmurs are almost always due to aortic regurgitation. Lastly, there are continuous murmurs, meaning that there are components of the murmur present in both systole and diastole. The only significant cause of this is a patent ductus arteriosus observed in infancy. Occasionally, a patient may have a systolic and separate diastolic murmur audible in the same region, leading the examiner to perceive a continuous murmur. This most commonly occurs with a combination of aortic stenosis and aortic regurgitation. The next characteristic to discuss is the murmur's location and radiation. Typically, when one mentions the location, they are more specifically referring to the location where the murmur is most easily heard. Traditionally, as can be still seen in many entry-level textbooks on the physical exam, words distinct and specific points on the chest were identified when murmurs caused by specific valves would usually be loudest. So, for example, murmurs caused by a problem at the aortic valve would typically be heard loudest at the second intercostal space just to the right of the sternum. Thus, this location on the chest wall was known as the aortic area. Unfortunately, in reality, the location of valve-based murmurs is not nearly so neat and specific, particularly for aortic valve murmurs, which can be heard basically anywhere in the chest. As a consequence, one should never assume the specific valvular origin of a particular murmur based solely on its location. The radiation of a murmur will seem obvious after you've heard a number of examples of actual patients, but it can be a difficult effect to clearly describe in words. It's most often described as the location where a murmur seems to travel to. However, I think of it as the location where a murmur is audible despite the stethoscope not being directly over the heart. Murmurs generally radiate in the same direction as turbulent blood is flowing. For example, a murmur from aortic stenosis might radiate into the carotid arteries, a murmur from tricuspid regurgitation can radiate to the anterior right thorax, and a murmur from mitral regurgitation can radiate to the axilla. The shape of a murmur describes how its intensity changes from onset to completion. There are three basic shapes heard: crescendo, decrescendo, and uniform, also called when occurring during systole, polysystolic. In general, crescendo, decrescendo, and uniform murmurs are heard during systole, while decrescendo murmurs are heard during diastole. The shape of the murmur is generally determined by the pattern of the pressure gradient driving the turbulent flow, with the loudest segment occurring at the time of the greatest gradient, since this will be the point of the highest velocity. Let's look at how the pattern of the pressure gradient driving the turbulent flow determines the murmur shape. Here we have a graph of intracardiac pressures as a function of time for a single cardiac cycle. The blue line represents the left ventricular pressure, the green line is aortic pressure, and the red line is left atrial pressure. As you can see, during systole, when the left ventricle contracts and its pressure increases very rapidly, there is a gradient of pressure between the LV and the aorta. That pressure gradient should not be there. Therefore, this is an example of intracardiac pressure tracings in a patient with aortic stenosis. Let's superimpose some heart sounds. Here's S1 occurring at the onset of systole and ventricular contraction, and S2 occurring at the onset of diastole and ventricular relaxation. You can see that early during systole, there is a relatively small pressure differential between the LV and the aorta. At mid-systole, the pressure gradient is much higher. Finally, towards the end of systole, as the ventricle is starting to relax and LV pressure is dropping, the pressure gradient is low again. Thus, we have the crescendo-decrescendo shape, which is a term borrowed from music in which a sound gradually increases in volume and then decreases in volume. Here's an example of such a crescendo-decrescendo murmur of aortic stenosis. The same analysis can be applied to every heart murmur. For example, here is aortic regurgitation. The turbulent flow here is occurring during diastole, when there is a pressure gradient between the aorta in green and the left ventricle in blue. Although there is always a gradient between those two compartments during diastole, only in aortic regurgitation is there actually backward movement of blood. As you can see, during the course of diastole, as the blood flows backwards from the aorta into the LV, the pressure in the aorta decreases, and thus the pressure gradient also decreases. This shape is known as decrescendo. Here it is again. Next we have mitral regurgitation. The pressure gradient between the left ventricle and left atrium remains relatively constant throughout systole, resulting in a uniform or holosystolic shape. see there is a relatively constant pressure gradient between the left atrium and left ventricle, with the exception of a pre-systolic accentuation, which is the consequence of the atrial kick.